Thank you for joining us. I'm really proud to lead the STORM team today. This webinar presents two exciting firsts for us. The first community engagement event since the pandemic. Welcome back, everyone. And our first ever webinar. The STORM skills training exists primarily for the benefit of the suicide prevention community. As a not-for-profit community interest company, we deliver a range of free and paid-for opportunities. We are pleased to bring you this free webinar as part of our community engagement program today. The topic today is responding effectively to young people who self-harm. The need in this area is illustrated by the amount of interest we have received in response to the webinar. Registrations from you all came in thick and fast, and all places were filled quickly, and interest was still coming in this morning. And I think I know why. Having worked with schools previously in my career, I am aware of the trickiness that self-harm in young people can present to you all working in the front line. It is heartening to see so many of you online today wanting to learn more about how to best respond to our young people who are in distress. We say that suicide prevention is everyone's business, and the same is true for self-harm. Responding compassionately can save lives. Everyone has a role to play, including me, including you, and including this man, Keith Waters, who will appear soon. Keith Waters is your chair for today's session, and he is the newest non-exec director on the STORM board, and will also chair our forming STORM steering group, where we are reviewing and improving our skills training package. We are lucky to have Keith as part of the team. He brings with him a wealth of experience in liaison psychiatry, self-harm and suicide prevention. He was awarded an honorary research fellowship by the Derbyshire Healthcare Foundation Trust back in 2013. And for many years, he has headed up the Derby side of the multi-centre study of self-harm in England, which he remains involved with. Until recently, he was a clinical director for self-harm and suicide prevention for the Trust and retains a post within the research team. Most importantly, what we love about Keith is that he emanates what this work is all about. He is compassionate, kind, non-judgmental, and very collaborative. He cares deeply about suicide prevention, and his passion is infectious. I leave you in the safe hands of Keith Waters. Enjoy the webinar, and I'll see you again at the end. Thanks, Keith, and over to you.
Thank you. Good morning, everybody, and welcome. A very warm welcome. Thank you, Bianca, for your kind words as well. Well, that's slightly embarrassing, but it does help to set the scene for today. And I really feel privileged to be asked to chair this, so I'll try and do it to the best of my ability. Next slide, please. Before we get kind of started, a few housekeeping, or maybe we should call them screen keeping items to kind of talk about. First of all, we're here till 12:30, and the majority of the time is going to be Ellen presenting, as well as then the opportunity for some questions and answers. We have asked for everybody's video cameras, apart from people involved with the actual delivery of this, to be off and the microphones off. It's more for a technical side and making sure it's manageable with so many people that's around. But the session is being recorded. It's already started recording, and therefore this will be available after the event, along with the slides to be picked up from the STORM website. In terms of accessibility, if you need to, there is the option to set up the closed captions or make them open captions, which is basically a verbatim text of what people are saying. They can produce some interesting results sometimes, but they're usually reasonably accurate. In regard to questions and answers for today, we've only set up, because to make it simpler in a way, the question and answer board for you to be able to ask questions. So if you have any questions at all, be they technical issues, of which the team that are working hard in the background will be able to answer, and answer those relatively quickly for you, or be they questions that you want us to explore at the end of the session with Ellen, and we're going to try and put them together. And I'd like us to kind of present them in a way that I can discuss with Ellen things that people are raising, as opposed to just saying, do you agree with this, or do you not agree with that kind of thing. And we'd really like it at the end that you do a feedback survey so we get some idea. And if we've not been able to address any questions that you've raised, you can email us after the event and the team will try its best to respond as fairly quickly as we can in regard to that. Next slide, please. I never, ever underestimate the importance of the potential effect of us talking about very sensitive subjects, self-harm, suicide, suicide prevention, etc. And I'm never surprised to find that they can be triggering, even when we're thinking we're okay, by actually exploring these things can in fact produce a response, which is why in our communications with you, we've highlighted for you to think about that and think about your safety and welfare, because that is really important to us. So hopefully you've thought about who you would talk to. One of our best strategies of dealing with distress and despair and suicide prevention is finding a safe and trusting person to talk to. That's equally applicable in many, many settings. So if you are affected by anything today, please, can you find that safe and trusting person to talk to? And if during the session it becomes difficult, don't feel you've got to stay here and listen to everything, but because it's being recorded, you can come back to it at a later stage. And just a reminder at the bottom, the Samaritans are there 24 hours a day, 7 days a week with a free phone line and various other things that may be needed. Next slide, please. You often find chairs of conferences going through people's CVs in great detail. I'm not planning to do this today because Ellen CV is readily available to be seen. And to be honest, you just need to Google her and you'll find the breadth and depth of her work and influence has been there for some time. But hopefully I won't embarrass you too much, Ellen, by doing a little bit of like a former This Is Your Life programme. Well, that shows my age to start with, doesn't it? I've been around and been privileged to be around the field of suicide prevention, you could say, for approaching about half a century. And what's been really lovely and a great privilege during that time is to see the growth and influence of many people in this field. Because in the early days, there wasn't a lot of people around and there wasn't much influence in all of this. None more so, though, in terms of influential people than to see the growth and influence of Ellen and how she's had. From local to regional, from regional to national. Indeed, now I would say she has significant international influence and recognition. Surprisingly, though, my first contact with Ellen was as a result of cows. Well, more specifically, it was in the aftermath of the foot and mouth epidemic, and there was training and support being developed for the at-risk community in rural settings. And although today's work in many ways will see Ellen's main area of interest, i.e. that in relation to children and young people, there's been changes in that Ellen has influenced. Early on, children were kind of seen as little adults in relation to what we knew about self-harm and what we knew in terms of suicide prevention. I would suggest that Ellen has helped to turn that on its head, to actually acknowledge that children and young people, we need to understand that and we need to influence that in regard to them as specific people and individuals in their own right. But what we are finding is what's relevant to children and young people is often relevant to adults. Maybe adults are just big kids, really, and maybe that's the bit that we can be thinking. So just to pull this together, I'd like to support the idea that responding to self-harm and suicide prevention is potentially everybody's business, not just about what the services can or should be doing, but includes the very important part about what we all can do in the variety of roles and contacts that we have with other people. Ellen and I have debated often the role of services, but also the role for individuals in their work, their personal settings and in their community settings, and the importance of this. Furthermore, the other bit that's really important is, I'm sure Ellen will deal with this within the slides as well, is the understanding that self-harm, suicide and suicide prevention are very complex areas. However, in reality, there are very many simple and effective measures and stuff that we can do that can make a major difference. I'm looking forward to Ellen's presentation today and the opportunity for us to explore and question later on. And Ellen, I'm sure, will give us a lot to be thinking about and to explore through. So hopefully that wasn't too embarrassing, Ellen. Over to you.
Thank you, Keith. Wow, what an absolutely lovely introduction. I can't thank you enough, and I'm really honoured to be here today at this first webinar. Thank you very much for inviting me. And in response to Keith's introduction, I would say that Keith has been instrumental in shaping my thinking in many ways with, I think, what I would call gentle, thoughtful, critical challenges. And I think that's really important. Okay, so I'm going to attempt to share my screen now. So hopefully you can see that, and I shall put it in presentation mode. Okay, so I'm going to spend the next 40 minutes or so talking about research from my research group, which is the self-harm research group based at the University of Nottingham. We are a group of academics and clinicians at all stages of career development. So we have lots of very bright PhD students. We have, sorry, slides are going forward by themselves. We have collaborations with senior academics across the world now. And we are, developing our research in many different ways, but particularly we're interested in children and adolescents, and we're interested in the psychological and social factors that lead to self-harm, and then what supports and services are useful in helping young people who are struggling with self-harm. So what I'm going to try to achieve in the next 40 minutes, I'll just very briefly say something about terminology, so the term self-harm, something about the scale of the problem of self-harm. I am going to focus in quite a bit on complexity, and that's something that our research group has been really concerned with and interested in for many years. And so we've devised new ways to try to capture this in our research, which we are now developing into clinical assessment tools. I'm going to talk about some of the literature on effectiveness in terms of psychological interventions and link that to our card sort task, which is capturing this complexity to demonstrate that what we found from our research is that the key transitions that move young people to a place where they feel like self-harming are modifiable. So we have lots of opportunity, as Keith already alluded to make a difference. I'm then going to reflect on some of the issues in accessing support that people who self-harm face and what we might do about that. And then I'm going to talk about the importance of involving people with lived experience of self-harm in research on interventions, and also in terms of how that might play out in different settings if people are thinking of setting up supports and services and care pathways. So a very brief word about terminology. We use the following definition of self-harm, which is any act of intentional self-poisoning or self-injury, regardless of suicidal intent. And this is a definition that is favoured in Europe, and it allows us to have nuance in terms of interpreting people's behaviour, and also allows us to think about ambivalence in terms of sometimes people aren't entirely sure what they wanted to achieve. And I think something that Keith and I have talked about a lot over the years is the psychological distress that underpins self-harm for behaviour, no matter how it manifests. And in fact, that's really what our focus needs to be on, not necessarily the act itself. It's that the pain, the emotional pain that's underpinning the behaviour that's the really important thing to pay attention to. Self-harm is an increasing problem, as you'll see in a moment when I talk about the spread or the ubiquitous nature of the problem now, particularly in young people. But for many years, it's felt to me that people don't take self-harm seriously, and particularly they don't take it seriously in young people. And we have a wealth of evidence now which suggests that we really have to. So I've highlighted here a paper from colleagues at the University of Bristol who looked at a transition from thinking about suicide to actually acting on those thoughts. And this was really strongly predicted by non-suicidal self-harm. So that's self-harm without any suicidal intent. We know from work by colleagues at the National Confidential Inquiry for Self-Harm and Homicide that self-harm, regardless of intent, is the strongest predictor of death by suicide. We know from some of the work that the multi-centre study of self-harm in England that both Keith and I are involved with is really important in terms of understanding the relationship between self-harm and suicide. And we've also shown the results that the National Confidential Inquiry has found in terms of self-harm being the strongest predictor of death by suicide. We've also shown through data linkages to the Office for National Statistics that those who died from all causes, whether they'd self-harmed or not, there was a 40 years of life lost impact for those who self-harm. So a significant impact on premature mortality for all causes of death. So these are very serious issues, and taken together, I really feel, and I felt very strongly for a long time, that responding effectively to self-harm is therefore an unmissable opportunity for suicide prevention. And I'm really pleased to say that now self-harm is included in the suicide prevention guidelines in England and Wales as an important issue in its own right in relation to suicide prevention. And then the final little point I want to make on this slide is you'd think that this being a big issue affecting lots of young people and the burden of suicide and the impact that has on families and communities, that this would be a well-funded area of research. And I'm afraid it isn't. An analysis by the charity MQ found that self-harm and suicide was one of the areas that actually receives the least funding in terms of research in this country. I'm not going to dwell too much on the issue of epidemiology and rates and so on, but I think it's fair to say that even before the pandemic hit, we'd seen a rising tide of self-harm. So there were a few surveys that came out. I have some data here from the Adult Psychiatric Morbidity Survey showing that in particular rates of self-harm that had increased in young women. Now in the pandemic, we've seen a really mixed picture, and I think we won't know the full impact of what the pandemic and associated mandated restrictions will have for a long time. We've seen calls to helplines for self-harm and suicidal thoughts and behaviours really increasing. But at the same time, we've seen presentations to hospital for self-harm and suicidal behaviours decrease. Obviously, there were lockdowns which prevented people from physically going to hospitals. And there's a concern that many people who were struggling with self-harm didn't want to go to hospital because they didn't want to burden the NHS. So I think overall, one could interpret the data that we have so far in terms of there being increased unmet needs. Okay, so now I'm going to talk about the complexity of self-harm. And I would like to propose that we see complexity as opportunity. Self-harm and suicide are what we call multidimensional. There's no one single factor that leads to any episode of self-harm or suicide. It's a complex culmination of thoughts, feelings, events, and behaviours. And this is represented rather eloquently in this figure, which is taken from a paper by Keith Horton and colleagues from the Lancet in 2012. This relates to children and adolescents, but could also be applied in many circumstances to older people. And so you can see we have genetic and biological factors, personality factors, exposure to self-harm or suicide, having means to hurt yourself available, psychological distress and hopelessness. And it can feel very overwhelming to look at a figure like this and think, goodness, all these things happening, what on earth could I do about that? But as Keith mentioned earlier, what I would like people to think about when they are confronted with this complexity is to consider the opportunities. We have interventions and treatments that can help with psychological distress and hopelessness. We can give guidance about and we can legislate for availabilities of particular certain popular methods of self-harmful behaviour, and we can encourage responsible reporting in the media around self-harm and suicide. So I guess one of the strong take-home messages today is to think about complexity more as opportunity. And I'm going to talk about some ways that we've been thinking about how we can harness that in our research. So we wanted to capture this complexity, and often in this area of research, you're trying to find out the contribution of a range of risk and protective factors over time. And uncommonly, we need very large numbers of participants in order to do that research. And that's one of the reasons that the multi-centre study of self-harm in England is so powerful. But even then, we can't cover everything. So we, several years ago, wanted to find a way of capturing this information for individuals that then could be aggregated to understand what might be happening across individuals. So we co-created the card sort task for self-harm with young people through some funding from the NIHR. And we were particularly focused on young people who had experience of being looked after. So they were living with foster parents or in care homes. But we also included young people who hadn't had that experience, so we could compare what the differences between those two groups. And as part of this work, we had an advisory group of young people who had lived experience of both being looked after and self-harm. And they were instrumental in making sure that the methods and things that we included in this task were absolutely appropriate for them and would enable us to capture the information that we wanted effectively. So we created the card sort task to try to capture these thoughts, feelings, events, and behaviour prior to self-harm and then what happened afterwards. We analysed those data using a technique called sequence analysis. It's not the only way you could analyse data from this task, but what sequence analysis allows us to do is to look at what are the important patterns, what are the really important steps that lead young people on a path to self-harm. And in this first study, we wanted to find out, if things were different between a first ever self-harm episode and a more recent or the most recent episode of self-harm. So you can see here a photograph of our card sort task running atop of along the horizontally of this array. You can see cards that have timestamps on them, so running from 6 months before self-harm right up to an hour before, then self-harm itself, and then what happened afterwards. And the cards placed underneath represent thoughts, feelings, events, and behaviours that we took from high quality prospective risk factor study in the literature, discussions with our advisory group of young people, discussions with clinicians that we were working with on this project, so that young people could choose cards that related to them and their personal journey to self-harm and put them in a sequential order. So in terms of how things evolved over time, so that you kind of follow the cards, this sort of snaking pattern up to self-harm occurring. We realized that we might have missed things. So we had blank cards that young people could add things that were relevant to their experience of self-harm, and they simply wrote that down and added it in to their card sorts if they wanted to. So we wanted to find out what the key patterns were. I mean, was there a pattern even? Could we say that, you know, self-harm displays a sequential pattern? And we use sequence analysis to try and capture that, which is a method that's used in all sorts of settings. I've got a picture here of social scientists who use sequence analysis to work out how people exited burning buildings. It's also been used in understanding mother-child, infant interactions, all sorts of different areas of research. But one really helpful thing about this technique is that you can look at events that happen in the past. So in our field, even when we try to use techniques like diary studies or ecological momentary assessment, we're often asking about things that have either just happened or have happened that day. So we're always asking people to think back about what's happened. The other nice thing about sequence analysis is that we can look at really complex causal factors. So all those things we can hold together at the same time without worrying about how many we can handle. And it allows us to look at this dynamic interplay of factors over time. So we had young people do this task with us. They had the card sort and mapped out their most recent episode of self-harm and their first ever episode of self-harm. The first thing I want to share with you is the top 5 cards that were selected on each occasion. As you can see, there's quite a bit of overlap. So I felt depressed and sad was the top card used on both occasions. Very importantly, I think, is this notion of not being able to tell someone how you're feeling. And then you can see we have self-hatred and isolating the self from other people as important cards. And finally, in the first episode of self-harm, feeling worthless was an important and highly frequently selected card. And concerningly, on the most recent episode of self-harm, feeling like a burden on people was selected. And if any of you are aware of Thomas Joyner's interpersonal theory of suicide, perceived burdenness is one of his kind of key factors in his model leading to suicidal crises. So here's a bit more complexity to share with you, but I want to show you what the card sorts can do in terms of helping us understand how these thoughts, feelings, events and behaviours transition over time. So we have a representation here of the most frequently occurring cards in what we call a state transition diagram. And we can see which of these cards occurred statistically more frequently, proximally to each other. And the stronger relationship, the thicker and the bolder the arrow. I'm just going to point out a few things on this one, which is to do with the first episode of self-harm. So number 1, the only factor to be directly proximal to self-harm was the notion of impulsivity and rashness. So I did it on impulse without planning. And then related to that was having something to harm yourself with, access to means. Then on point 3 on this figure, you can see what we call a vortex of really negative thoughts and emotions of swirling around depression, self-hatred, anxiety, and feeling worthless. And then on point 4, what I think clinically is really important, this idea that young people just can't trust anyone enough to tell people how they're feeling. And that has all sorts of implications, I think. And then 5, quite surprisingly at the time, but actually there's a little more literature which speaks to this now, which is feeling better after self-harm. So something about the self-harm had made the young person feel better. Moving on, this is what happened in the most recent episode of self-harm when we represented that using this technique. Again, number 1, you can see that impulsivity is again the only factor being directly proximal to self-harm. And then as well as access to means, you can see that self-hatred has now come in as an important transition on this most recent episode. Also, the negative cognitions, thoughts and emotions are still apparent. Feeling hopeless about the future has come in now, which was not necessarily the case for the first ever episode. And then very concerningly, the idea of wanting to die, so suicide ideation has crept in as a significant transition. And then finally, just to bring your attention to something that has now disappeared over time. So feeling better after self-harm has disappeared as a key transition on this most recent episode of self-harm. So we thought this is a really useful research tool to understand the complex thoughts, feelings, events and behaviours that underpin self-harmful behaviour in young people. We noticed that actually our state transition diagrams and the way that things sort of move and pattern do actually fit quite nicely with some contemporary models of self-harmful behaviour, such as the integrated motivational volitional model, which has been proposed and tested by Rory O'Connor and his group. But also we noticed that young people, as they did this task, were having kind of light bulb moments. They were really having insights about what had led to their self-harm that they hadn't really had before. And we had quite a few comments like this, that they really loved doing this task. It gave them an experience to think about what was happening to them. So it got us thinking that this might be a really useful tool to support conversations and assessments around self-harmful behaviour. And one of my PhD students, who Dr. Jo Lockwood, now works at the Institute of Mental Health in Nottingham, she explored this a bit more and using the cards in a slightly different way to scaffold an interview around impulsivity and self-harm. So she focused in on that bit of the state transition diagrams that we saw for both the most recent and first ever self-harm, which was this idea that, you know, it was done quite impulsively without planning. And she adapted the card sort task to focus particularly on impulsivity and did this really nice interview based study with young people. They really liked doing it. Again, there was young people who did this study with Jo, really valued the opportunity to use the cards. They liked the idea of talking about stages and progression and change. They also themselves demonstrated this kind of multidimensional understanding of impulsivity, this kind of rash, emotional driven behavior. It made sense to them. But encouragingly, having recognized it in themselves, they also felt that it was something that could be changed. They didn't feel that it was something that was completely fixed for them, that it could be changed. And then we noticed that I talked about the kind of swirling negative cognitions and emotions. Again, these were really important in this study. And it really came out that this idea of tolerating these negative emotions was really, really problematic for these young people. Okay, so I'm going to take a slightly different tangent now and talk about how interventions that we have existing already in our toolkit, in a clinical toolkit, are useful in terms of the complexity framework that I've just proposed. And what do I mean by that? So we think that the implications from the card sort task are that many of these important transitions that young people have told us are important to self-harm. This is the thing about the card sort task. Young people can tell you the story, the journey of their self-harm in their own way, in their own time. And what that has shown us is that these transitions are modifiable. There are things, there are interventions that we have that we can do things about. So we can do things about access to means to hurt oneself. We can look at and deal with and challenge negative thoughts and emotions, and provide interventions for impulsivity through cognitive behavior therapy, dialectical behavior therapy, mentalization-based therapy, and group emotion regulation. And for many years, I've been involved with Cochrane systematic reviews, which is a particular way of gathering all the evidence that's relevant to a research question around the effectiveness of certain interventions to work out, what are the things that are helpful and that might work. So I'm going to just tell you about one of them today, which is particularly pertinent to young people, which is a systematic review on interventions for self-harm in children and adolescents. And this was led by Kat Witt, who you can see pictured here, and Keith Horton, who is one of the real sort of titans of research in our field. And I've been lucky enough to work with him for many years now, including on these systematic reviews. So in this review and synthesis of the literature, we were looking for studies that had included young people up to the age of 18 who'd self-harmed within 6 months of entry to the trial. So we were looking for trials that had measured self-harm as an outcome after the treatment. And what we found from this systematic review, so pooling all the evidence from around the world, published and unpublished literature, is that a particular type of talking therapy seems to be really promising, which is dialectical behavior therapy. So we see a lower rate of repetition for dialectical behavior therapy. Now, this is a very intense therapy. It borrows tools from other therapeutic approaches. It involves mindfulness techniques. It involves very intense contact with therapists, and it lasts a long time. And I think that's something that might be quite important here. This kind of idea of extended contact therapeutic contact could be important for young people. But we also recommended in the conclusions of this systematic review that we should explore cognitive behavior therapy as well, because in a different systematic review, which we've conducted for those who are over 18, we've shown that cognitive behavior therapy, which is a talking therapy, which helps us to think about the impact of our thoughts on our emotions and then on our behaviors. That looks really positive in adults, so it might be worth thinking about it for children as well. So there is some hope. What I would say about the literature on interventions, given the problem of self-harm in children and adolescents, we still have a pretty impoverished evidence base, and we need many more trials and interventions and many new interventions to really move this field forward, which is something that we are trying to work on quite intensely now. I just want to mention sort of non-clinical interventions, more universal preventative interventions that might be helpful, particularly in school settings. I'll just briefly want to tell you about the SAILI trial, which is not research that's carried out by our research group, but by colleagues across Europe. And just to hold in mind that actually this intervention hasn't been trialled in the UK, but I feel that there's evidence aplenty in Europe that this worked in European settings, so we should probably try to find a way to test it in UK settings. What they essentially did was a massive plus a randomized controlled trial. And so this figure on the right-hand side here, where we've got some blue boxes, shows that they were trying 4 different approaches to see if they could move the dial on suicide attempts and suicide ideation within schools. So in one arm, schools were randomized to receive gatekeeper training, so teachers and frontline staff. In the second arm, schools were randomized to receive a youth awareness program. In the third arm, schools were randomized to receive professional screening with referral. And the fourth arm, there was a control group. So they, I believe, just received some posters to put up in the school that were also used in the awareness program. And the bottom line is that the Youth Awareness of Mental Health program managed to reduce suicide attempts and severe suicide ideation in this trial. So that was the one of these 4 different approaches that were trialed. The youth awareness of mental health was the thing that emerged as looking most promising. And on the left-hand side of this slide, you can see what that involved. And it's not too intense. You've got 5 hours over a sort of 4-week period, including lectures and role play and having posters in the classroom. Now, one of the things about complex interventions is we can't always tell what was the most kind of active ingredient of that intervention, but we do know that taken together, this seemed to have a really positive impact on suicide ideation and attempted suicide. Right, I'm going to now just briefly talk about issues with access and support, which will be relevant for anybody who's working at the front line with young people who self-harm. I've already mentioned this idea from our card sort task and the key transitions leading young people to self-harm, about this issue of young people really struggling to talk to anyone, how they're feeling, because they just can't trust anyone. And this has really come out in our interview study work as well. So we've done a lot of qualitative interview work with young people. And these 2 quotes from a study we published in 2018 really do highlight this as well. I'll just read the top quote here. "I can't stand there and talk to someone because I just get really anxious and I can't do it. I just don't trust anyone." So that's something to reflect on and think about, well, why is it that these young people really struggle to help when they are in emotional pain and distress? Unfortunately, even when they do pluck up the courage to ask for help, accessing support is very difficult. Many young people in our experience fall down between the gaps in services and actually get sent away with no actual support whatsoever. Sometimes they'll get a leaflet, for example, about harm minimization, which is this idea that, teaching people to harm themselves in a safe way, or use sensation proxies, and by that I mean things like elastic bands or drawing on yourself with a red pen or using ice cubes, is promoted as a solution. And actually we've done some research in this space, and for many young people these approaches are perceived as being unhelpful, and in fact sometimes they turn into a method of self-harm themselves, so using a really large elastic band to hurt themselves, or digging in really hard with a red pen. Now, that's not to say that these approaches aren't helpful for everyone. Some young people did find them helpful, but I think we would never recommend that these techniques should be used on their own. There must always be some other kind of support for that young person. And I have a couple of quotes here from the study, which we ended up calling "These Things Don't Work," because we felt that that was the predominant message that was coming from young people. And again, it relates to this idea of not dealing with the psychological distress that underpins the self-harm and just focusing on the behavior itself, which does not recognize the pain that underpins these behaviours. And by pain, I mean emotional pain. And finally, to say, again, unfortunately, even when young people access services, manage to get services, they encounter real problems in clinical settings with negative attitudes, patronizing attitudes, and empty promises. And so again, this is some information from a study that we published based on interviews with young people, which basically said that there are a lot of really unhelpful responses in the clinical setting for young people who self-harm. And again, that has a negative effect on future help seeking as well. So how do we solve some of these issues with accessing treatment, finding treatment to be supportive and useful and appropriate when it is accessed? Well, for me, the most important thing that we need to be doing moving forward is to involve those people with lived experience for whom we are designing supports and services in the process. And this would apply in any setting, in any frontline setting, whether it be in the community or in clinical services. And this is where we've started to move our card sort task into development in terms of an assessment tool, because young people told us that that's what they thought it would be useful for. So we did some work in a project which we call Cafe Connect, where we went into the community and we talked to young people in a relaxed setting, in a private room, in a cafe. And we talked about how we might develop this tool further. And actually what they wanted was for it to be an app, and they could see it being used as an intervention. So I'd got as far as thinking, well, this could be a really useful assessment tool, but they'd gone kind of 10 years ahead of me, and they were talking about it being an intervention and an app. And many years later, we've been lucky enough to be awarded some funding to make this happen. So we are delighted that we're leading one of the MRC Adolescents Mental Health and Developing Mind programs at Nottingham. And I'm co-leading a program called Adolescent Mental Health and Development in the Digital World with my wonderful colleague, Professor Chris Hollis. And as part of this work, we will be working really closely with clinicians and young people to develop the card sort task as an assessment tool. So it's going to be co-created with young people. We're also doing work to think about how we might use this task as a training tool. And Keith and I had a go at seeing how this went down at a National Suicide Prevention Alliance conference a couple of years ago, where we presented a fictitious kind of card sort of a young person, then said to people, well, how would you approach working with them? How would it help you to have this information? What could you see as a kind of plus in terms of using the card sort task in this way? And I've been really lucky that I was, before the pandemic hit, able to go over to the States and work with David Jobs, who is one of the world leaders in designing collaborative assessment tools. So we've got some really nice international collaborations going on and moving forward. So I'm going to stop by just summarising and just emphasising that self-harm is serious, it is complex, and it does change over time. However, we've seen from our work, and indeed work of other groups, that those key transitions are modifiable. We can do stuff to help at all those different stages. Talking therapies are great, we need more of them, and we need to think about the barriers that young people face in terms of accessing that kind of support. And we must develop more new tools and include young people with lived experience to ensure that what we produce is actually meaningful from them. I just want to say thank you to all the very many people that I've collaborated with over the years, and particularly the young people who have advised us and challenged us along the way, and all the frontline workers who've worked with us on our various projects. We've got a bunch of resources on our website. There's a film about the card sort task. We have an electronic version if people would like to look at it, and we can send that out to you with the caveat that at the moment it's a research tool, but we're thinking about all different ways that we might use it in the future clinically or in different community settings. We also have an evidence-based leaflet called It's Okay to Talk About Self-Harm, and we developed this from our research and other research in the field to help scaffold safe conversations about self-harm. So if you're worried about saying the wrong thing and you're worried about you don't know enough about self-harm, it's a quick stop tool to think about, well, how could I support someone who might be self-harming? And finally, to say, absolutely, as Keith said at the start, these are tricky topics and we never know quite how it's going to impact on us. So I really would echo what Keith said about, having had some time to reflect, do think about who you might reach out to if you found anything that's been talked about today or might come up in the Q&A difficult. And I'll stop there.
Thank you, Ellen. Yes, I know I've seen some of this before, but I always find it quite fascinating, and you bring such an interesting perspective. It's such a calm and a lovely way of listening to you. So, I think that helps the subject matter to kind of get embedded within. So a really, really big thank you. For the next kind of 25 minutes or so, we've got some questions that people have raised. I'd like to take the liberty, as it were, of using them as a foundation for us maybe having some discussions about things as well, because I think it's interesting to provide a variety of perspectives. So to start with, Daniel put a question to us, and I'll read the question out and then I'll put that other bits that maybe we can be thinking about, because I think in some ways he's answered part of his own question in the way that he's put it. I've got a question about self-harm as a predictor of death by suicide and how it breaks down by gender. Young women and girls are more likely to self-harm than young men and boys, and that men are more likely to die by suicide than women. So I was wondering if self-harm is equally a stronger predictor of suicide for both all genders or not. And I think the thing I want to kind of explore a little bit is that idea of risk groups and volumes, etc. Maybe our responses that get rather overwhelmed by our fear that somebody might die, which is a predictor, it is there, but also that bit about the difficulties, if not the dangers, of trying to become predictive.
Yeah, it's a really good question. And there are some statistical difficulties here as well. The question clearly shows knowledge of the different demographics in terms of self-harm and suicide. Keith, I recall from our work in the multi-centre study when some years ago, gender was looked at, and I do think that being male and having a psychiatric history and a history of self-cutting were the things that really were the strongest sort of three things. It's always very difficult. I mean, I think it's really important to bear in mind that not all suicides are captured as suicides in official data. And females tend to use more passive methods that are a bit more open to interpretation by coroners. So there might not be the kind of weight of evidence unless there's a note and so on to confirm a suicide. So some of those deaths might be a bit more accidental. Well, categorized as that. So it's all quite a messy picture. But I think in general the finding is that being male confers the strongest risk, and I'm happy to be corrected on that, Keith, but I think that's probably a fair representation of the literature.
I think you're right. I guess the difficulty is then when we're trying to deal with an individual in front of us, how that then relates to what we do or what we don't do. And the worry is that sometimes we're trying to use that evidence in order to support doing, or maybe sometimes doing less with an individual. And how potentially dangerous is that? Because just having suicidal thoughts put you into a more risky group, because that ideation might work into action, and therefore that action might be something that then be a self-harm act, or that self-harm might lead to somebody's death. And the self-harm is there, but proportionately as well, most people that self-harm don't go on to take their own lives.
Yeah.
Most people who have suicidal thoughts, which is actually you and I probably at sometimes, that don't go on to act on them. So how do we work with that, and how do we manage that?
So I think the bottom line is that we have to take all self-harm seriously, because it's such an imprecise science, and on that individual level, we know that the predictive tools that we have are useless. So all the kind of screening tools that we have about sort of predicting future risk of suicide work about as well as asking someone, do you think you'll do this again? So I would say, no matter the pathway in, I would take all self-harm seriously. And that doesn't mean to say, completely freaking out about it and the burden of that on the person who's taking it seriously, because I think sometimes there's a bit of a defense mechanism that goes on with, well, that's not serious, I can just disregard that because that's not serious and it doesn't really mean anything. But actually taking it seriously, gives us a bit of responsibility. And I think that's what many clinicians would say now. And I don't think it's something that people would dispute, that when someone is in distress, we should take them seriously.
It's quite worrying, isn't it, that bit that you found about young people's view of not trusting others, and particularly their experience of those within care type settings within the services, and how that responded to. And that some services actually, either written or unwritten, have kind of exclusion criteria. Whereas, having suicidal thoughts, having self-harmed, should be something that should open the gates for the opportunity to talk and the opportunity to help. But sadly, for many, it seems to be a barrier to even open that gate, let alone do anything more.
Well, you have to be exactly the right risk. So not risky enough and you won't be referred, and too risky, you won't be referred. So, we're awful at dealing with risk as human beings generally. But I think we do have serious problems in the way that services are, and pathways to care are allocated in terms of, risk determination.
And I guess as individuals, when we encounter somebody in the non-caring settings, how we respond in that way is important. It's providing that safe and trusting opportunity, because talking makes such a heck of a difference. It doesn't have to be specialised talking of a therapist that's had 10 years of practice. One human being to another, one human being to a younger person, or two younger people together, taking each other seriously is probably very, very powerful.
Absolutely.
Thank you, Daniel, for that. I took the liberty of extending it slightly, but I hope that helps. We've got a question about the evidence of DBT being effective for young people who self-harm and have suicidal ideation, who also have a diagnosis of ASD. I think it's a real interesting one, and what I'm finding fascinating is, I think we are starting to, and we should learn more from those from the autistic spectrum, because I think they provide us with some insight into dealing with distress and despair. In fact, many of the people I used to meet in A&E when I was doing my assessment, at the time of their distress and despair, had many of those similar characteristics of being difficulty to manage emotion, not being able to put things into order, etc., which are the very characteristics of why many with ASD may struggle with emotions and different situations at times and articulating them. So, DBT and ASD, what are your thoughts?
It's a really, really interesting and excellent question. And I think partly what it's making me think is about problems with diagnoses. And often, so DBT was created by Marshall Linehan, and particularly for people who struggle with borderline personality disorder, of which there's a lot of problems with emotion regulation, impulsivity, suicidality, self-harm. So a lot of the things that we've talked about today. Many people who are on the autistic spectrum have been misdiagnosed as being borderline, in my understanding, and then later on, with further assessments, are revealed to struggle, and have autism. I think we've got a really interesting programme of research at Nottingham, led by Dr. Sarah Cassidy, who's really expanding on this field, which has been really neglected actually. And we're actually seeing if we need to modify the card sort task for this group. So we've been working with autistic people to see how we might be able to modify the card sort task. And I suppose one of the things about talking therapies in general is I think people who are autistic really struggle to articulate how they're feeling. And so part of our feeling about the card sort task, and this came out some of our focus groups with young people, is they felt it would be particularly helpful for people who have ASD. So I think that's a really good question. I think we're really just at the beginning of our understanding of how people who are neurodiverse fare in those different types of interventions.
I think they've got a lot to offer us. I think they've got a lot to offer us in the sense of understanding people who are in crisis, people who are struggling, how we might at times, because some of the things that they're experiencing on a more day-to-day basis are the very things that people will struggle with when they're faced with their life crisis, where their emotional pain is taking over the situation, and they want to find ways of dealing with it and coping. And as you say, modifying the card sort task based on that, using those sorts of techniques, exploring things in that way, I think provides us all with an understanding that actually may well help in the assessment and indeed in the treatment, because talking therapists need the talking bit. Well, what happens if talking about your feelings is a major difficulty? How do you do that? And again, it shouldn't be an exclusion. It should be one of those ways which opens the doors. We need to be thinking more imaginatively and more open about that.
Yeah.
So, okay, we have a question. Do we class excessive drinking of alcohol as self-harm? I deal with work-based apprentices, and this seems to be very common with them to deal with issues.
It's such an interesting question. So in terms of the formal definition that I gave at the beginning, it probably wouldn't be included in that definition, but I think that's open to interpretation. And I get asked about all sorts of methods. So one is young men who get into fights and who drive too fast and have accidents. And we do for certain groups that we work with widen that definition, because we suspect that some of those behaviours might actually be self-harm. So I'm thinking particularly of the work that we did with young offenders, where again working with the young people themselves and the youth offending team workers who are supporting them. They said, there's a lot of kids who will deliberately get into fights. They will drive too fast and have crashes. So it wouldn't be in the official, but it's associated. We know from the work in the multi-centre study for self-harm that alcohol use is incredibly important in terms of self-harm and suicide attempts, particularly running up to and very close to an episode. Thinking of the work that Jenny Ness has done, Keith.
Yeah, we know that depressing and disinhibiting effect of alcohol can be part of the final stages of a self-harm act occurring, or somebody moving again from ideation to action may well be because of that disinhibiting effect of alcohol. But again, there's that commonality, isn't there? The fact that it's dealing with whatever has caused the emotional pain or the difficulties, resulting in a behaviour to try to manage that. So whether it's driving too fast, whether it's taking alcohol, I guess we need to be coming further back along that line about what are the things that people might struggle with, and what are the things that may help to equip us so that, we can't take away pain and difficulties. Being a human being, we are exposed to lots of difficulties, but how we manage them, how we communicate with them, and how others communicate with us at the time is probably quite key. Your card sort task is wonderful at dealing with that emotional bit, but I'm thinking your own problems paper as well. There are clusters of things that will be occurring that will be leading people to be struggling. If we know that already, maybe there's stuff that we can do so they don't get to the struggle of overusing the alcohol, overusing the drugs as a way of coping, or self-harm as a way of coping.
Yeah, that's really interesting that you've brought that up, because what I didn't really have time to talk about when I was presenting the card sort results is that we have these bins which are low frequency items and medium frequency items, which they've been kind of binned together because they didn't quite make the criterion for being included as a transition in their own right. And a lot of the problems, the life problems, are in there. So the card sort captures them, but they don't quite reach the threshold on their own. And the reason is heterogeneity. And by that, I mean, people experience lots of different problems. There's not just one problem. So they're in there, but they're just not articulated as a kind of single reason that was they're part of the transition, but we haven't identified one particular problem yet. But that might be a question of numbers, and the more we do this work with larger numbers of people, we might get more of a fine-grained analysis where things, I'm thinking about difficult childhood experiences and things like that might pop out.
Yeah, the first time I saw you present the card sort task, my immediate reaction was this could be a real adjunct to doing a self-harm assessment in an A&E department following a self-harm act, because that ought to me to be telling the life story, so the person's context of how they've got to here is some understanding, and then focusing very much in what's the recent things that have been building and what have you, and then that 48 hours prior to this event occurring. And I saw the card sort task as something that would help that communication, because it's not always easy to find the right words or the right bits of sequencing things, but actually putting it in the context of the person's whole life experience. Because quite often in A&E, when a young person would tell their story, it all made sense when we knew the background picture. In the context of that row that they had with their friend or their mum, or that exam result, it didn't quite fit. It's only when it's put in that longer term context. And then understanding that shorter time about the event that may well have raised the temperature of the emotions that were occurring, and then the acts that occurred. I'm rambling a bit, I do apologise, but does that make some sense?
It does. And I think the thing about the cards is that what they do is they scaffold. That is quite a burdensome thing to do. Cognitively, that's hard work. Yeah. And the cards help with that, I think. And also they give permission to mention things which are almost unmentionable. And so we find that, people disclose things in the card sort task that they won't disclose in an interview study. It's almost giving them permission to say, yeah, that happened to me. And thinking about the kind of context of therapeutic intervention, it might be that someone chooses that card and says, look, you need to know this is an important part of my journey here, but I'm nowhere near ready to talk about this, but important you hold that in mind and think about any kind of treatment that we might, think is useful for this particular person.
Yeah, because there's always a dilemma, isn't there? We don't want to re-traumatize people. We do need to understand their story, and actually telling their story can be quite influential, but overtelling it and not being able to go back. And again, the card sort test can prevent that happening repeatedly, because once it's done, it's there. That's what the sequence was. So you don't need to ask about it again at another time. I've got a feeling that's something that's perhaps emerged in what you've been doing and what you're thinking.
Absolutely. Young people tell us all the time they have to keep telling their story over and over again to different people. Whereas if you kind of have it mapped out and in an ongoing, even in an ongoing therapeutic relationship, you don't say, let's go all over it again. It's like, what's changed? Is anything different? Do we need to move things around? What's gone up? So there could be, again, it's a way of reducing the burden of that, retelling, like you said, the trauma or whatever's happened for that, what's happened for them to be in the position that they're in now.
Well, I took us all around the houses for a question about alcohol, but I think it's all interrelated and connected. Okay, I've got a question now based on supporting people who are engaged in self-harm in IAPT services. If people come through the service and have self-harmed in the past, or are engaging in self-harm, and they then get placed on a waiting list for treatment, what kind of thing would you recommend suggesting to them in terms of support while they're waiting for treatment, if the leaflets based on solutions are often helpful or unhelpful for young people? I think there's more than one question in here, or more than one comment about what's happening here, but over to you to answer the difficult bit.
It's such an important question. And it's a huge issue, and the bottom line is that for pretty much all mental health services, the demand outstrips what can be offered and what support can be given. So I would always say doing the really basic things well, like sleep, eating, exercise, talking, really steeling yourself. And if it's, if a young person's come with the family saying, look, the burden is on you to notice when things are changing. The burden is on you to really say, are you okay? Are you really okay? Because don't forget that children will be protecting their families from how they're feeling. So I think, you know, there is no, I mean, there are, you know, things that might suit some people, like doing exercise or meditation. It's very, very individual. There's no one size fits all kind of solution for that very difficult period, I agree, for accessing statutory services. I mean, there are amazing charities who have talking-based support, like I'm thinking about text services like Shout Crisis, who you have, it's, you know, you can text. There's obviously Samaritans. There are, you know, third sector organisations around the country that support people in this situation. I'm thinking about Harmless, which is based in Nottingham, but, you know, they work nationally. So there are these kind of alternatives, but it's maddening, and I think it's something that moving forward we've got to think more carefully about. I mean, we were involved in the National Coordinating Centre for Mental Health care pathway competency framework mapping, and it's all well and good having those things mapped out, but if people can't access them, it's you know, it's useless, isn't it?
There's a little bit in that question there that worries me, and has worried me for a long time, about our engaging in self-harm and then get placed on the waiting list for treatment, almost implying something that it's part of maybe that exclusion track, or it's not the right time to start because you're self-harming. You know, if somebody's struggling with their emotions, probably feeling quite anxious, probably feeling quite low, and they are trying to manage that, or either consciously or unconsciously, with self-harm being part of the picture, to then not, if the care is ever delayed because they're self-harming, I kind of think it doesn't quite fit for me.
The tension, I think, there's that which is worrying, really, really worrying. And then there's the, oh, well, we don't want to, we don't think you've got a mental health problem, so we don't want you in that system. So, and that's true, that not everybody who self-harms has a diagnosable mental health problem. So, you know, moving forward, more community-based approaches, you know, counselling in schools, things like that, actually might be more appropriate, or arts-based interventions. I'm really keen on arts-based interventions, and actually one of the most exciting things I've been doing recently is work on socially assistive robots. So we've, which sounds really weird, but what they are cute little fluffy robots which teach in situ emotion regulation. Again, this is really preliminary research, so it's not stuff that I would say go out and do this as something we know works. We have been working with young people who are struggling with a range of mental health problems to see how having one of these robots helps or makes a difference. And the bottom line is that so far it's looking really encouraging. And the most recent study we've done with university students who are anxious has also been really encouraging. So you know, comforting the robot, so you learn self-soothing by soothing the robot. A bit like having a pet, I suppose. You know, you're stroking the pet and it calms you down. So in the future, that might be something that I would be kind of hard and fast recommending, but you know, we're at quite early stages with that research at the moment.
Okay, this is a slightly flippant part of this, but I remember delivering some training where I was talking about safety planning and going through the various bits, and some part of the group that put get a dog, get a dog, get a dog, get a dog for almost all the various bits. But actually it made some sense. Who do you talk to when you're struggling? That can talk to the dog. What can you do to distract? Take the dog for a walk. What about the exercise? And in fact, it was relatively simple, but actually it made an awful lot of sense. And maybe that's part of what we need to be trying to do, is demystify all of this. And right at the beginning, I talked about the simple things that we can do, because it can be those simple things that can make quite a lot of difference.
Yeah, I mean, safety planning is a really good tool as well. I mean, again, it's mostly used in the clinical setting where you would collaborate between the client and the clinician to map out a safety plan of, when you're in crisis, this is what you do. But I mean, there are online resources for creating a safety plan.
Got a question now. There's a lot of fear from parents about raising the subject with their children. How would you suggest that we might do this? and where can I get support from as a parent? I think your leaflet also addresses it to some extent, but maybe we can revisit that a little bit now then.
Yeah, this is something that comes up all the time, both around self-harm and suicide. And the bottom line is that talking about this in our experience and in terms of the worldwide literature is not iatrogenic, and by that I mean it won't make things worse, especially if it's done in a sensitive, compassionate and non-judgmental way. And those are really key components. And I think I'm a parent, and I know that when my children have problems, I want to solve the problems for them. I want to get in there and what is it? And I have to really steel myself to sit back and let them tell me what is going on for them and be non-judgmental about it, and to think compassionately about holding that distress for them. And I think most people working in our field would say that talking about this stuff saves lives. And there's a myth that it's going to make things worse. I mean, obviously, if you do it in a really horrendous way, and I have had some, stories of absolutely awful conversations that young people have had with teachers and so on, and even, psychiatrists. But, if it's done in a compassionate, sensitive, non-judgmental way, which is led by the young person, I think these kinds of conversations can be life-saving. There's a really good leaflet called "It's Safe to Talk About Suicide," which was produced by Krista Malones at the University of Exeter. So if you Google that, that's a fantastic resource. And we have found that people found our leaflet really helpful. So we've got feedback, and we've been doing some qualitative work around how people have used the leaflet and what they've taken away from it. And they certainly feel that it's a helpful tool to start those conversations, to think about having those conversations.
I guess the next bit with this is, we know reducing access to means is a really good suicide prevention strategy within all of that, and therefore but the flip side of that is trying to control somebody's self-harming by setting targets about reduction, particularly with self-injury and bit. From where I sat clinically for many years, seemed to be so counterproductive. If you try to set a goal that, okay, last week it was 3 times, next week can it be 2 times? It'll end up be 5 times, because you're focusing on the behaviour, not what's driving it. Now, again, that's a very simplistic view from myself. How would you view that? How would you? How do we help parents manage, when they've found out their young person is self-harming, and the great desire they're going to want to have to stop it happening? Yeah,
I think that's it's incredibly painful to see your child in distress like that, and of course you want to make it stop. But I think you're right, clinical experience and research experience, it tells us that trying to focus on immediate cessation is not helpful. And we use the word recovery a lot in mental health research, and I mean it's a bit of a loaded term these days, but actually it's not linear, it goes up and down. People that have in quotes recovered for years may struggle further down the line. So again, I totally agree with you. Focusing on just the behavior is unhelpful. It's what's underpinning that, what is the distress, and what can we do to help ameliorate that. That would be my focus.
And maybe going back to some of the things we talked about earlier, taking all self-harm seriously is important. It's not the depth of the cut or what have you, it's almost the level of the despair, etc. But our responses do need to be proportionate as well. They need to be trying to be geared towards what might be best to help this person move forward, but not try to control it. It's tricky, isn't it? It really is not an easy bit, and no wonder do the individuals who are experiencing this struggle so much, but the parents who discover this will struggle. And we, as in professional settings, we haven't got an absolute answer, but we have some things that guide us. And I just think reiterating the taking all seriously doesn't mean that everybody has to be referred to services or end up with major care packages around, but it is about acknowledging, validating and supporting, and trying to provide that kind of proportionate response that best meets that individual. Again, I was rambling a bit there, so anything you'd like to add to that?
I don't think so. I think that's absolutely right, and I think just creating the space for things that need to be articulated to emerge and to support those in a constructive way. I'm certainly not suggesting that everybody requires psychiatric treatment, and I think we need to do much better at thinking about some of these core things that underpin self-harm, like emotion regulation, like impulsivity. So these are almost skills that we could be teaching in primary schools. So thinking about prevention rather than a sort of more reactive thought.
We haven't got enough evidence yet, have we? But the Seeley study is really, really important to do in that. But how can we capture that kind of doing the simple normal things are as effective, if not more effective sometimes, than maybe some of the therapies or interventions? It's tricky to do, but we need to be finding out much more, don't we?
Yeah, we have some evidence from what we did a study. We asked young people what they had found helpful and what wasn't helpful, and all the helpful things were talking to friends, my pets, doing sports, so the recommendations that I made earlier are evidence-based in the sense that they've come from young people themselves. Unfortunately, the things that they found least helpful were some of the services, but that was very, again, there were some people that found child and adolescent mental health services really helpful. It was a very mixed picture, but there's a wide range, and I think that's the thing about thinking about that complexity and heterogeneity, that don't think one size fits all. And even if you try something and that's not quite right, then what else could we do?
One quick one, I think, and then a slightly broader one that might just leave us thinking as we bring this to a close. Should we think about the card sort tasks perhaps with young people who use drugs and alcohol and also self-harm? And can we support young people when they're influenced by their peers? How can we support young people when influenced by peers?
Yeah, well, that they are influenced by their peers all the time, and we know that peer influence is really different for teenagers than it is in adults. I mean, we know this from all the kind of cognitive neuroscience research. Absolutely, this could be adapted for alcohol and drug use. We've been thinking about how it might relate to eating disorders. And so I have a student who's working on developing a card sort task for people who are struggling with eating disorders. And I think absolutely it would be adaptable for thinking about what leads to problematic alcohol and drug use would be really fascinating, and how those things kind of interact. So with eating disorders, there's often comorbidity between self-harm and eating disorders, and there's a bit of a mixed literature on if you're coping with self-harm, then your eating disorders out of control, or do these things kind of go consonant together? If that you're feeling bad, they're both so there's all sorts of interesting things that could, we think, be unpacked by using these sorts of approaches.
There are more questions than answers, but we need to keep exploring that. I won't read the next one out indeed, because we're just about at the end of our discussion, but somebody has actually reflected on their journey of their young child in regard to what we've been doing and saying, and how some of the experience you've described have been there. But hopefully that what we've done today is something that is quite helpful and useful for people to kind of think about this. We've given some pointers, but no direct answers to everything. But I want to thank you very much, Ellen. I really do, and it's not because I know you're the light. I do find these absolutely fascinating. I think you've got such a lot to offer this. And when I go back on that journey, when we first met, the stuff that you've helped to bring forward and shape and influence, particularly for young people, but I think it's reflective over the adults as well, I think is tremendous. So it's been an honour and privilege to be here today. Keep up the good work, and thank you very much. And I'm going to just hand over to Bianca to kind of pull things together.
Well, thank you. Unfortunately, there are no hard and fast answers in any of this, but I think having these discussions and reflecting is really important, and I'm really privileged to be able to do that with you. Thank you.
And thank you both very much. What an intriguing and helpful session. Thank you so much, Ellen. I'm looking at, I've written a whole heap of notes, and I'd really like to refer to them, because I think it's important that we reinforce some of the key messages that have been, that you've shared here today. And I really like this idea that complexity is opportunity, and self-harm is complex. Humans are complex. So I thought that was really helpful to help people to lean into that complexity. And I agree, it is self-harm it is very, the closest or best predictor of suicide. So of course it's an unmissable opportunity for suicide prevention. Taking all self-harm seriously is so important, and that focus on distress and emotional pain over the behaviour can help young people. So I think that's a really important message that we can all do when we're thinking about having conversations with young people about self-harm. And I think what we need to reiterate also is to have conversations that are sensitive, compassionate, non-judgmental, and are led by the young person. And we know that talking, it does save lives. So leading into that. I also, what came to mind is something that a sentence came to mind as you were talking, which is meeting the young person where they are rather than where we want them to be. And I think that's really key, isn't it? It's about meeting them where they are. I would personally love one of the soft, fluffy robots that you were talking about, although I may have to stick with my 2 fluffy dogs for now. So I'm looking forward to what technology and innovation and the young people, I love that this is young people, can bring to this. And I think, thinking about what we can do, what we can learn from diversity, how to empower young people to talk about the unmentionable, all of those things. And what's so inspiring about your research, Alan, is, we're talking about those 3 key elements coming together. We're talking about research, we're talking about practice, but we're also talking about the voice of young people and ensuring that's included. And I think that's a real strength of what we're doing. So thank you for sharing your time and expertise with us today. Keith, thank you so much for doing a great job of chairing today's session. I would also really like to thank the amazing Storm team behind the scenes. They've been working hard to ensure everything runs smoothly for you all today. Martin, Emma, Danny, Kirsten and Jez, thank you all very much. Storm is very lucky to have such a strong team. I'd also like to thank the audience, and I think you would all agree this has been an incredibly informative session. If you have any questions that we've not been able to get to today, please email them to inquiries@stormskillstraining.com, and we'll do our best as a team to answer those questions for you. The slides and recording of the event will be uploaded to the Storm website in the coming days, and you'll be notified via email on their publication. I'd also like to thank you all for attending. There was over 350 people online today, so that is really heartening to see so many people wanting to learn more about responding to distress. Before you leave, we have a few requests from you all. First, please let us know how we've done today. You'll be invited to provide some feedback about today's session, and you can see a link on the screen there. Also, let us know what you'd like from us in the future. Please take the time to give us your thoughts on that. Secondly, join our community by subscribing to our communications list. It's free. As mentioned earlier, Storm is here to support the suicide prevention community. We do this in lots of ways. By subscribing, you'll be informed of upcoming opportunities, both paid for skills training courses and free community engagement events like the webinar today. Finally, as both Keith and Alan have mentioned today, be aware of your own reactions to today's presentation and content. and the question and answer time. Please look after yourself and chat to somebody, a trusted person. Thank you all very much, and we'll see you next time.
Thank you. Take care.
Thank you. Bye.